This is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. We are still doing our sessions in basic emergency care course, which is based by WHO, which is designed by WHO. This is a trauma module. In this session, we are going to discuss regional injuries. For regional injury, we'll start with head injury. Symptoms and sign, presence of headache, altered mental status, pupil inequality or lack of reaction to light, presence of scalp laceration or depressed skull fracture, bruising around the eyes and behind the ear, blood coming from the nose or ear, presence of weakness in one side of the body, hemiplegia or hemiparesis, convulsion and seizure, changes in the visual field, loss of memory, and vomiting. Because brain is enclosed in a rigid skull, any swelling in the or bleeding can cause raised intracranial pressure, and it's a life-threatening condition. Whenever there is suspected or confirmed head injury, we need to monitor this patient closely. We need to do the Glasgow Coma Scale plus AVPU. Whenever there is head injury, you have to immobilize the spine because frequently these patients have cervical spine injury. Monitor for vomiting because vomiting increases the risk of aspiration. If there is suspicion of fracture base because of blood coming or fluid coming from the ear or nose, you give antibiotic to guard against infection and meningitis. Make sure you recognize and manage hypoglycemia appropriately. Anyone with GCS less than 9 should have a CT done in 2 hours. Facial fracture, this can be recognized by deformities and unusual movement in the facial bone, jaw not closing properly, problem with eye movement. Whenever there is a fracture on the facial bones, suspect head injury and a C-spine injury, and you have to immobilize the spine. These patients, they need antibiotic for open facial fracture. You need to assess and update tetanus vaccination. Patient should be positioned appropriately to prevent blood from entering the airway. And in this patient, if you need to use airway adjunct, you're going to use, you don't use nasopharyngeal airway. Penetrating wound or injury to the eye, you can see object is stuck in the eye, or there is a painful red eye or reported feeling of something in the eye, problem with vision, abnormally shaped pupil, clear liquid draining from the eye, sign of trauma around the eye. For this patient, do not push on the eye, do not remove this penetrating object, give appropriate antibiotic and update tetanus vaccine, elevate the head of the bed, and place patches over both eyes. And this patient needs specialist management, and you need to call for consultation or transfer to appropriate facility. Penetrating neck injury, patient with penetrating neck wounds are at risk of airway obstruction. Neck wound may cause significant bleeding, and this can compromise the airway. You can see laceration or puncture to the neck, swelling suggesting hematoma. You have to look carefully. And for this patient, maintaining cervical spine precaution, stabilize but do not remove the object, apply firm pressure to the bleeding side, do not block the airway, make sure you don't block the airway, do not insert anything into the wound, plan for consultation or transfer for specialist management. Regional chest injury, patient might present with difficulty in breathing due to lung injury, and sometimes the difficulty in breathing due to lung injury develop over time. Simple pneumothorax can progress to tension pneumothorax. Patient can have tachypnea, shortness of breath, crepitus or tenderness with palpation to the rib. You can see crepitus or tenderness. And there will be uneven chest movement and unequal breath sound and hyperresonant percussion, not in case of pneumothorax. For this patient, you need to give oxygen, you need to monitor closely. If suspected rib fracture with crepitus and tenderness, consider that they will be an injury to the chest or abdomen. This patient, if they are in tension, they need a needle decompression and then chest tube, and you need to assess who will do it and the competency of the provider and the ability of the facility to handle this patient. One of the regional injuries, abdominal injury. Severe pain or bruising is concerning for organ injury and internal bleeding. Patient can have abdominal pain or vomiting, tender, firm, distended abdomen. Patient can have guarding, that is strong contraction of the abdominal wall muscle when it is touched. Bowel sounds could be absent or reduced. There could be rectal bleeding. Some patient with open wound, they can have the bowel prolapsed outside. And sometimes patient with bleeding, internal bleeding, they can have bruising around the umbilicus and on the flank. For this patient, you need to secure IV line, you need to give IV fluid and prepare blood and give that as needed. Keep them fasting because you might need to go for exploration. If bowel is visible, leave it outside but cover it with sterile gauze soaked in sterile saline and give antibiotic. And then you have to decide if you can handle them in your facility and call appropriate consultation, a surgical consultation, or you need to transfer to another facility. Spinal cord injury, the patient can present with midline spinal pain or tenderness. There is movement problem like weakness, paralysis, and also there will be decreased reflexes, sensation, pins and needle, or loss of sensation. They can have sphincteric disturbance. They do not control urine and stool. Some patients present with periapism, and those with spinal shock can have severe hypotension and bradycardia. On examination, you can see crepitus to the spine bone, spinal bone not aligned, and some patients have difficulty in breathing, especially in upper cervical spine injury. For those patients, whenever the patient is unconscious or he is conscious but has neck pain, cervical spine tenderness, numbness or weakness, you have to, or anyone with neck injury or head injury, you need to immobilize the spine and keep the patient flat. And when you want to do exposure, you have to do the log roll. And those with hypotension, they need to get IV fluid. And then you need to decide if you have appropriate service to manage this patient or you need to transfer. One of the critical problem not seen in primary survey is internal bleeding. This can happen in the chest, abdomen, pelvis, thigh. You can see those with chest injuries, they can have shortness of breath. Those with abdominal injury can have bruising around the umbilicus and on the flank. You can see pelvic or femur fracture, and you see feature of hypoperfusion, hypotension, tachycardia, pale skin, diaphoresis, and impaired capillary refill. For this patient, stop bleeding if possible. You can use a pelvic binder for suspected pelvic fracture, spleen the femur. You need to give fluid and prepare blood, and then you need to decide about the triage. Those with suspected pelvic fracture can have pain with palpation of the pelvis. You can see instability or abnormal movement of the bone in the pelvis. Some of them can have blood in the penis or rectum. For this patient, you need to secure IV line, you need to give IV fluid, prepare blood, you need to do good analgesia. You can use a pelvic binder to stabilize the pelvis. Do not rock the pelvis to perform repeated exam. And then you need to decide where you can manage this patient. Extremity fracture with poor perfusion, you can see deformity or crepitus of the bone, Absent pulse beyond the fracture, capillary refill could be prolonged more than 3 seconds, and cold extremity, blue-gray coloration of the skin beyond the fracture. And in the management, look for sign of poor perfusion beyond the fracture. Feel the pulse, check capillary refill, and observe skin color and pallor. If weak pulse or poor perfusion reduce and spleen the fracture, always check pulse capillary refill before and after reduction, give adequate analgesia, and then arrange for handover and transfer if appropriate. Open fracture, consider it an open fracture if there is a wound more than skin abrasion near the fracture site. Open fracture are emergencies as they can lead to severe infection. For this patient, you can see deformity, crepitus of the bone with overlying laceration and abrasion. If there is bleeding, you need to control bleeding with direct pressure, perform immediate reduction, and splint if there is poor perfusion, irrigate the wound well, dress the wound, give antibiotic and update the tetanus vaccine, splint the wound, and then you need to see if you have appropriate consultation or you need to transfer this patient. Open wound, you can see laceration, abrasion, check for blood pooling under patient around the axilla, genital area, buttock and back. Pumping or squirting blood suggests arterial bleeding. For this patient, control bleeding by direct pressure. Clean wound with soap and water and antiseptic. Remove any debris. Dress wound with sterile gauze. Check perfusion beyond the wound before and after dressing the wound. Splint-like laceration to help with healing. Stabilize but do not remove penetrating object. For snake bite, immobilize extremities. For other animal bite, you have to consult expert. You need to update tetanus vaccine, and then you decide where to manage this. This will end our talk about regional injury. Thank you and see you on the next session.